information. Okay, with no further ado, as soon as you gentlemen come in and get settled, we're going to be learning about the challenges and the continuum of stay-at-home versus nursing home care from Dr. Carrey.
Thank you very much. Hello, everybody. Before I start, I think there should be a yashikayach goes out to those of the people who come here to attend these sessions, because if you're here, it means most likely you're here. Maybe we can close the door because I don't have a microphone.
Okay, he's very soft-spoken.
Because you've taken off time on a beautiful Sunday, probably one of the last Sundays of the year, that you can enjoy outside or do whatever it is that you like, to come here to probably find out some information that will make your caring for somebody a little bit easier. So, yashikoyach to all of you. We just read in the Torah a few weeks ago when Eliezer, before that, when Hagar was sent away from Abraham and Yishmael got sick, it says, when he got sick and there were troubles and there was a hard time to deal with. I can't move the pole. Anyway, when Yishmael got sick, so Hagar's reaction was she just left him over there and she let him take care of himself. That's not the way we do things, and obviously the people here have an interest in doing things in a much more hands-on Yiddish way. So, kol hakavod to all of you who have come here, and hopefully you'll be able to take home some information that will make that job a little bit easier. Now, the question that is raised in the ad for the session says, what are the stay-at-home or nursing home? It was interesting, I looked at the other topics, and nowhere in here, except for one of the sessions, does it even refer to the elderly. And I think that's appropriate, because not everybody is here because of taking care of an elderly relative or an elderly friend, but really we're here to take care of people who need help. And it could be a parent, it could be a sibling, it could be a child, it could be that we're just good Samaritans in helping take care of, somebody who needs the help. And we try to tone up our skills a little bit to do that. Just by a show of hands, how many people here are involved in taking care of an elderly parent? Child? Not an elderly child, a child. Spouse? Someone not related? Okay, so for the most part, we're dealing with our parents or our spouses. Some people have issues that they have to help take care of their children. I will take the liberty of using the example of the elderly just to make the transition through the different discussions a little bit smoother, because that will be sort of more of a common denominator. But anything we talk about really has to do with anybody who needs to have some sort of assistance or guidance in taking care of or making decisions for somebody who needs assistance in some way. So let's get started. The things that we are also that we take care of, and we're not going to be comprehensive obviously, but sometimes it's an issue that has to do with the elderly. It can have an issue that has to do with people who are physically impaired, people who are emotionally impaired, intellectually impaired, and it could be a relative in any one of those categories or things that we need to help. Most of the discussions will describe patients or clients, as the other vendors might use the term, for people who are involved in the healthcare decision process, but we know that that's not always the case. It's not always true that the person we try to make decisions for can help make the decisions. I just want to tell you a little bit about myself. I'm not an expert in this field. I do have a significant amount of experience. When I grew up in Far Rockaway, and I see a number of Far Rockaway people here, so that was a long time ago. My grandmother lived in the neighborhood. She lived on Nielsen, which at that point was more of an elderly block. Those of you who know Nielsen know that now a lot of young couples live there. Her apartment house had quite a number from people but they referred to each other by their apartment number because most of them were Bubbies and Zadies were living there. So it was Mrs. 4K, Mrs. 4D. They all had long European names, and that's how they used to call each other. And they lived in these apartment houses. They were independent. They would have family in the neighborhood, so they would visit regularly. But they went to shul, they did their shopping, they had activities all by themselves. And as my grandmother got a little bit older, she ended up moving to the JASA building, which is on Seagert, Beach 19th. And that was really more of a sort of an independent living center where they had a lot of the common needs built into the system, but they all had their own apartments. They still lived independently, and she thrived over there. And then she got a little bit older and a little bit weaker and more frail, and she ended up in more of an assisted living situation, and ultimately she aged and she ended up in a hospital, and then she passed away there. But this was the spectrum of what we see in the typical elderly patient, geriatric patient. And most of the individuals that we deal with, there is a spectrum where things start at a certain level and things may change over time. And part of our job is to keep track of those changes over time in order to see what needs the person has. Just my professional background is I went to school in the 5 towns. I was in Yeshiva Rockaway, for those of you who know it, the year it opened up. So that was a while ago. I did most of my undergraduate and graduate training in Brooklyn and Brooklyn College, downstate, Brookdale, Kings County. I spent a few years in McGill doing my fellowship. Then I was working in Westchester for a number of years, and now my practice is actually in Woodmere, and I will be making a transition in the next month or so. So I'm not handing out cards because my professional status will be changing soon. Maybe Achiezer will have information down the road. But part of that transition is in order to try to help this type of population more than it's been helped in the past. I do take care of primary care patients in my practice. I'm a subspecialist as well. I work in one of the assisted living centers in Atlantic Beach, the Nautilus. Some of you may be familiar with it. I see patients there. I'm not part of their system, but I do see patients there, which I think is mutually beneficial because as we'll discuss, having access to care for the people who are living in some of these facilities makes it much easier for them. I do see some patients at home mostly as I can on more of a favor basis than as a professional basis. I'm hoping to incorporate that into my new practice as it transitions. But having seen some of those patients and having seen patients in this assisted living and making nursing home visits, in addition I also work in Camp Simcha where we have 110 kids every session who have significant needs not dissimilar to a lot of the individuals that we're taking care of. And we learn a lot of lessons from them, how their families are able to keep them at home, even with the significant medical conditions and handicaps that they have. And most of them are living at home with whatever it is that they need to take care of them. In addition, I'm in Hatzalah, so I've been to many homes, and we see a lot of the situations that take place. And hopefully I'm going to glean from that experience in order to give you some guidance in whatever way I can. So I'm not an expert, but hopefully I can help share some of my experience. Before we get into the specific question of where is appropriate for someone to be, just a little housekeeping and some terminology that we should all be on the same page. And I understand that if you go through the room and everyone had time, and it would be nice if we could, to discuss your own situations and your own experiences and those things that you've done before. But I'm sure many of you have been through a lot of these issues that I'm going to discuss. I'm sure some of you are familiar with a lot of the terms that we'll discuss. But I'm going to go through some of them anyway, just to make sure we have the same building blocks. So, first question I'd like to throw out is, if I told you that someone came to me and asked me about their loved one and where is the best place for them to go, and they said, well, it's just too hard for me to take care of them anymore, so I think I'm going to send them to, let's say, a nursing home. Is that the proper approach that someone should have? They're saying it because I am not able to do it, so therefore I'm going to send them. Shouldn't we be looking at what's best for the patient? Or is that not true?
What's best for them?
So the answer is, in many aspects of medicine, our job is to look out for our patient, and that is our sole determinant. So if we have a patient, my patient's in the emergency room, and they need an ICU bed, and they tell me there's only one ICU bed and 2 patients need it, I'm going to try to fight for my patient to get that bed because that's the best for my patient. But it could be that my patient may not really need the bed so badly, and there may be someone else who needs the bed even more. But my job is to take care of that patient. When it comes to caring for others and being a caregiver, the caregiver very much does play into the equation. Taking account the caregiver's needs and the caregiver's resources is very important, because otherwise the caregiver will be out of the picture before you know it. They can get burnt out, both physically, emotionally. So it's important for us from the starting point to realize that this is not something that we should look at as a guilt trip, that we are not being able to provide what we think is the best. But it's the whole gestalt of what's going on, that the caregiver has to be part of the equation when we make decisions. And therefore, not everybody who you're taking care of in this room, and not everybody who needs assistance is going to get the same assistance just based upon a checklist of items. We have to take into account that what we can provide for them is going to be important. And if we can't provide for them, then we're not doing them a service. The other thing that I wanted to just say from the outset, and this is something that's a very important take-home message, and I'm sure many of you are familiar with it, is that when we do make decisions, we should not be making decisions in a vacuum. Number one, many of us are going to be doing it with other relatives. It could be siblings, it could be children, it could be, other family members. But we should try to have other healthcare professionals to give us more of an objective opinion about what things might be necessary. It's always good to have a spiritual leader, such as a Rav or some other mentor, who will help guide you in terms of certain aspects that may come up. And networking, like you're doing here today, with other individuals, other caregivers, other institutions that have experience in these types of things. All those aspects are important, and you should always remember that you should always fall back on those individuals, those groups, to try to give you extra guidance. So let's get started with what will be sort of a brief presentation, and then we will try to get some questions at the end. So we're dealing, for the most part, with seniors who need further help. So we know that we all live in our homes, and change, and I'm guilty of this also, we're not so excited about change. We like to stay where we are, we like to be where we are. A lot of us, if we have to go away for Shabbos, we say we'd much rather be in our own bed at home. That goes for our elderly or our people that we have to give the care to. Unfortunately, as we get older and we do get wiser, obviously, we don't always have the same independence as we had before, and sometimes it's difficult, if not impossible, to move on to some more skilled situation. We do try to keep people, and we try to keep ourselves home as long as possible, but that's not always possible, as we said, because of the needs of the individual, the needs of the caregiver. And the feelings of guilt, as I pointed out before, should not really play into the equation. We should just make sure we look at it as objectively as we can, and realizing that our limitations are there, and we have to deal with the limitations in the best way we can. None of us are looking forward to this, and none of us asked for this, but we've been given the schus of helping out somebody else, so we should take advantage of that opportunity. There's also been something that most of us have probably grown up with, that whatever you do, don't put me in a nursing home. That has been the tzava many of us have gotten from our parents in the past. And for some of us, it will be possible to live up to that, and for some of us, it won't be possible. But whatever it is, the myth that the nursing home is objectively an evil and bad place to be is certainly not the case, and certainly not in the year 2015. So there are really three simple things that we need to do, or someone should do in thinking this out. The first one is to plan out what options are available, and we're going to discuss that in a few minutes.
Please, we didn't mention it before, please silence your phones, put them on
It's okay.
vibrate.
So we should plan out what options are available, and we're going to discuss what are the basic different types of options you have to send or provide for somebody when they need the extra help. The second one is to realize that not one size fits all. We may have people here that we may say, oh, my mother needs this and this, and you say, oh, that's exactly what my mother needs. It doesn't mean the solution is going to be the same for each of us when we try to come up with a plan. And the third thing we need to know is that we want to put somebody into the least restrictive setting that we need to. So that we don't just put someone who needs a little help into a nursing home if all they need is someone to come and help them out during the day for a few hours. On the other hand, if someone is not in a safe situation, we need to make sure that we're providing them with enough help and assistance to make sure they are in a safe environment and getting what they need. It is true that when we make these decisions, we are sometimes going to balance their needs, their wants, their quality of life, and their safety. And there are times that we will be more permissive in letting someone perhaps stay at home, even when it's not the safest environment. But from a qualitative standpoint, for that person, it may be something that's just so important to them that they're willing to bear those extra safety issues, or the family will bear those safety issues. So we have to realize that it's not a simple answer, but we have to take into a lot of considerations, and it's not a perfect equation that there's a perfect answer. Sometimes we will err on the side of maybe less safety, but more quality, and sometimes we will not. But that's something that is considered. Because it would be tragic if we went to an extreme and we gave somebody too restrictive an environment, or if we gave someone an environment that was not restrictive enough for what they need. Just so that we're on the same page and we have the same vocabulary, I'd like to, I don't know if there are enough for everybody, so if not, share, and if not, we'll try to get some more.
Yeah.
I better take one of them. There are 3 different parts on this sheet. We're going to do the first part first. I'll start describing it as we hand it out. There's something called ADLs, and probably a lot of you are familiar with the term. ADL means activities of daily living. One way healthcare professionals and the insurance companies and the visiting nurse services and the institutions that provide aids are going to evaluate an individual by seeing what are their ADLs, what are their abilities to do the activities of daily living. So we've defined that a little bit to make it so we are all on the same vocabulary. So that if someone is rated in a certain level and another institution gets a referral to help provide services, they will know that what those ADLs stand for. So it's really very simple, but it helps quantify what the person's needs are. So simple. We're going to get more, so please if you could just share in the meantime. Simple ADLs include feeding, the person's ability to feed, and if you notice on those of you who had the sheet, there are 4 ways of categorizing each one of these ADLs. One is, can they do it independently? Do they need some help to do it? Are they completely dependent on someone else to do it? Or they cannot do it whatsoever? For example, feeding. Some patients could eat by themselves. Some patients just need someone to put the food in front of them. Some need to be fed, and some cannot be fed because they can't eat because it's just not safe. The others include toileting, going to the bathroom. How independent are they to do that? Selecting their clothing and getting dressed every day. Just their general grooming. If they shaved, are they shaved? Is their hair combed? Are they tucked in? So they're wearing soiled clothes. Maintaining their continence, which is obviously a significant issue. Putting on their clothes. Bathing on a regular basis. And just walking or just transferring even from a chair or a wheelchair, whatever the case may be. Are they able to do that? And how much aid do they need to do that? There's another category of ADLs, which are called the instrumental. Those are a little bit more sophisticated. So those are things like managing their own finances. Can they get the bill in the mail, open it up, respond, write out a check and mail it? Do they need some help just with opening the envelope? Do they need someone to do it for them completely, or they don't even understand what it is? Getting transportation, that means getting into the vehicle, out of the vehicle, summoning the vehicle, making arrangements for the rest of the accessory to come, doing their shopping. Can they do simple shopping? Can they do all their shopping? Can they do any of their shopping? Can they use the telephone? Is it safe to leave a telephone with them to know that you can communicate with them? Can they manage their medications? That's a very big issue because even patients usually most people nowadays in the geriatric category are taking some sort of medicines. The medicines could be very important. How they're taken, what time of day they're taken, are they taken in the right quantity, are they being mixed properly? So those are things that are important for us to evaluate while we're making these decisions. And then simple housework. Can they vacuum? Can they make their beds? Can they maintain the other little things in the house that need done? So that is the vocabulary we sort of use in trying to make these evaluations. Put the sheet to the side for a minute. We're going to move on to the next part. So once we understand how we're going to evaluate these individuals, so now we're going to springboard to what are the types of individual places that patients can go to. So now we're going to discuss sort of the burning question, which I should not burst your bubble, but I'm not going to give you an answer to the question, where should your loved one go? Hopefully we'll just try to sort of feel it out a little bit, and maybe you'll have a little bit of a better understanding how we can make evaluations by the time we finish. So how do we select housing? If you look on your sheet, it will show you that there are 5 different categories of types of housing. This is not complete in that this is the only list, but these are sort of the categories that include just about all the types of places patients can go. We're going to the last one I'll just mention at the end, just a little bit what it is, but really we're looking today to answer the question. If you look along the column on the left side, the senior housing, and again, the term senior is not necessarily only senior, it's also other individuals who need housing of some sort. So one is living at home. So is it possible for someone to live at home, and what would it take to make that possible? So we're going to try to go through and answer some of these questions, like when does this work, why might it work, and what else might be good to know about it. And we'll try to summarize at the end the answers that we're going to discuss now. The second group is what's called independent living. Independent living means they're living basically on their own, but they're no longer in their own house, in their own apartment. Maybe they're part of a complex where everybody else is in the same category, and maybe the complex is offering certain services, but basically they're still taking care of themselves. The third category, which is probably the big first transition, is assisted living, and that's going into an environment where now they need to have more assistance. And then the final stage sort of is, for the most part, is a skilled nursing facility. And that's the one that offers the most assistance in terms of their help. Just to be complete, the continuing care retirement community are the types of places that they invite someone in, and when they sort of are independent, they say, here, we're giving you an apartment, we have buses if you need, you have your own kitchen, you do your own cooking, and we may make it easier for you because we're all collectively here in the same category. But if it comes a time that you need more assistance, so we could just transition you with our staffing and our arrangements, you can stay where you are, and we will now categorize you as assisted living, and we will give you whatever it takes to keep you here with all that level of assistance. Some of them even offer that at some point, if someone needs to go into nursing home environment, it will all be a transition from the same institution. So it becomes, you move into there and you know that you're set no matter what your levels are. And if your levels change along the way, because sometimes people need nursing home care along the way, because let's say they needed an operation, they need recuperation, so a nursing home might be better suited to do that, but then they may be able to go back to a less sophisticated level of care. So we're going to discuss each one of these for a couple of minutes and hopefully fill in some of these blanks. So if someone is living at home, obviously that is sort of our unstated goal. Keep somebody at home as long as we can, but what will it take? So again, going back to the ADLs, this is a very important question to ask. What are their daily needs to keep at home and be able to be safe? So most of the time, if someone is home, it means they could basically dress themselves, they could feed themselves, they could do at least simple grocery shopping on their own, they can cook, it's safe for them to take care of their medications. And then if they need something filled in, they may be able to get help either with a cleaning aid or someone else coming in during the day to help with little things, maybe some of the heavy housework. But living at home sort of requires that the assisted daily living activities are being taken care of by the individual. As the family members of those, we may be filling in some of these little spots where they need a little help. Maybe we'll do some of the grocery shopping, maybe we will help clean up the house, maybe we'll send somebody in. But for the most part, the expectation is that they are getting this complete package where everything is taken care of somehow. As caregivers, we very well may be part of that picture, and that's what home care basically is. The next step would be the independent living. So the independent living gives a little bit more assistance. Some of it is built into wherever they are. It may take some of the burden off the caregiver. The burden on the caregiver may be the same. But there are certain warning signs that will tell us that somebody is going from one level to the next. So some of the flags, and this is not an exhaustive list, but this is just a list of things that those of us in this world of caregiving will know that these are some of the things that we've probably noted from time to time. So you go to their house, they're supposed to be living okay, they're doing all their shopping, they're eating, and you go and you notice that there's spoiled food on the counter, there's spoiled food in the refrigerator. You ask them why, they sort of don't have good answers. They have appointments that they used to be able to go and independently attend, and they're forgetting to go to their appointments, either to the hairdresser, to the doctor, wherever it might be. They're just not keeping up with those appointments. You may notice some bruises on their arms or legs, and you say, like, where did that come from? And they can't really explain why they're suddenly having bruising, and you suspect maybe they're either falling, maybe something fell on them, maybe they're just not being careful enough. You notice when you go in and you say, "Oh, come over, come stand up," and you notice they're having more trouble getting out of their chair, or if it's someone who's already in a wheelchair, you might notice that now they can't get out of their wheelchair as easily as they can, so they just have that difficulty with getting up. They may have trouble, you notice that they're walking, they're sort of stumbling a little bit more, their balance is unsafe, and you notice you're getting a little concerned. Obviously, forgetfulness is one of those things that we are all concerned about, not just with the people we're giving care to, but everyone, every time they forget something, thinks, okay, now it's my turn. But forgetfulness is obviously a very common thing. When we focus on it, it sometimes gets us nervous, but sometimes you notice that there's a consistency in the forgetfulness, and that raises a red flag. The hygiene is often an issue that we notice, that hygiene is not up to the par that it should be. Maybe they're not showering as often as they should. Maybe they're not changing their clothes as often as you would expect them to. We notice their grooming and their personal care just isn't what it's supposed to be. Maybe the house, which used to be immaculate, suddenly dishes are left out, furniture is not placed properly, the bedroom is not clean, the beds aren't made. You may see mail that used to be, methodically opened and taken care of is now piling up without any attendance. You may notice that they have bills that haven't been paid. You get a notice from one of the utilities that they, usually paid exactly on time, and now they haven't paid. They may be losing weight, and you don't understand why. Look, you're going shopping, you're having food. How come you're losing weight? They may not be as interested in things that they used to be interested in. Oh, well, the kids are coming over. Oh, like they just don't have that same interest or excitement. Obviously, forgetting to take medications is a sign, and it's also an issue that should be addressed. And you may say if they're still driving, you may notice that there are a couple of dents on the car that they can't really explain. Hopefully just theirs and not somebody else's. So those are some of the warning signs that we worry about. At that point, it doesn't mean they have to go to another level of care. It doesn't mean they automatically need to go to an assisted living where they're going to be provided for that. It does mean we need to do something. Baruch Hashem, in our society now, if you go upstairs to the vendors, which I haven't seen yet, but you'll see that there are a lot of vendors who are providing the different levels of care that people often need. And it could be something as simple as having a companion to go for walks with them. It could be someone who will do their grocery shopping either with them or for them. It could be not just an official organization. A lot of the schools have chesed organizations where the kids will go and help and do some of these things. You have to glean on the different places that can offer these services. It could be volunteers. It could be people you may want to pay. And you can help them monitor their diet. Someone can help with their just getting dressed and their grooming. Sometimes you could bring in someone to do some light housework for them and take care of that. Maybe they could get a walker and their balance will be better. Someone could do their laundry, make their beds, help them with the bills in the mail. Now a lot of this may fall onto the shoulders of the caregiver. As long as it's not exhaustive, then that's okay. But otherwise, you may try to reach out and find where can you find resources to help you with some of these things. Some of them are obvious, some are sort of obvious. Getting a pill box to make the pills more orderly and available. Making a list where they could check off what medicines they took. Helping with the dishes. Someone pick up their prescriptions if they need. Answering their phone messages. Maybe they can't get the phone messages themselves anymore. All these things, if it's on a small scale where it just needs a little fine-tuning, it is possible if you are inventive, it's possible if you have the right contacts, it's possible if you have the right finances, you could probably get some of these things done if they're on a mild level. When they get to a level where it's no longer simply available to just have someone and take care of that, so then we have to start thinking about going to the next level. It's also important to know that when we do get aides or someone to come help in the house, there are a lot of different levels of sophistication of that aid that we can get. First of all, one could get someone from an agency, and we know, I'm sure, if you go around the room, I'm sure at least some of the people here have found people on their own that they pay privately that are not through any organization or any institution, that they pay to help out, take care of somebody. Those of us who have done that know that that could be a blessing. That could be a godsend if you have the right person, someone who is trustworthy, someone who's had experience, someone who has references. If you get someone like that and you know that they took care of my neighbor's mother for the last 6 years and now she's available to take care of my loved one, that's a great way to go. That's not always available. Sometimes we have to rely on agencies. We do need to know that anybody you bring in, you has certain restrictions and limitations of what they're allowed to do. The agencies don't allow the regular aides to do certain things. They can't necessarily give medications. They can't necessarily treat a simple wound. They can't do anything other than what they're assigned to and what they're qualified to do. So if you do bring somebody, make sure that they're going to provide what you want. Don't just say, I'm bringing someone to the house, and now I don't have to worry about the shopping in the car or this, the 10 things. You have to make sure that they're qualified to take care of that. You just heard a story about somebody who had someone came in the evening time to help shower and change and put someone to bed every evening, and that was their job. And they came in every evening for like an hour and a half, took care of all that. So by the end of the day, the person was put into bed, clean, all set up, and back into bed. One day he went on vacation. Someone else from the agency came in, and instead of a full shower, he started to give him just a sponge bath. And the wife said, like, why aren't you doing the full job? He said, well, in our agency, we're not allowed to give a full bath if there's a glass door on the bath, because then there's a potential danger that if the glass breaks, something can happen. Now that is a very important rule, and you need to know that. You may need to change your glass, or you may need to change the way things are done. But we need to know exactly what limitations there are in both what we're providing and what we need provided. The other thing to know is that nowadays there are many agencies that not just provide aid. 5 minutes? There are other companies around that will provide home services, medical home services, x-rays, blood testing, things like that, things that you might need to bring someone out for, which could be a big tircha if someone's a caregiver needs to provide the transportation. You should speak to your healthcare professional. There are a lot of agencies that could do a lot of the testing at home, and the patients don't have to go out. They could do physical therapy at home, occupational therapy at home, wound care at home. A lot of these things are potentially available depending on your specific situation. 5 minutes. Okay. If that doesn't work, then often an assisted living is going to help. And even with the assisted living, we still need to take into account the daily living needs. Some of the assisted livings, there are still, the goal of assisted living is to be independent with all those things provided. So now there's a communal kitchen, and there are communal activities, and there are a lot of the things, daily living responsibilities, wash, laundry, things like that are taken care of. Still, some individuals may need more than that. So some of them in assisted livings will have, depending on the status of the institution, they will allow them to have their own personal aides come in and help them. As I mentioned at the beginning, I work in the assisted living in the Atlantic Beach, the Nautilus. There, some of the residents are completely independent, and everything they do, they go to the dining room themselves. And some of them, actually, the other spectrum is some of them have 24-hour aides to make sure that they can do all those things that they're offering. So they are able to stay in the assisted living setting with a lot more independence, but they still have that personal caregiving on a regular basis. So that's until assisted living. And the answer is, when do you go to the nursing home? And the answer really is when all that is inadequate and you can't provide the care, where the person can't even eat by themselves, and they may need to have a tube to help them feed, and they may have other catheters, and they may have other devices, they may have ventilators, they may have other things that you just can't provide for in that type of setting, where the assistance is limited in the skill and in the amount that is being provided. So the skilled nursing facility is usually going to be after we've already exhausted the other opportunities. And as I said, sometimes those opportunities will change with the person's needs. If someone was in the hospital, they may be able to go back to the assisted living. A lot of the patients I care for in the Nautilus, when they end up in the hospital, the first thing they want to do is get back to where they were, because now that became their home. I'm going to have to sort of skip along just to get to some of these other points. But those are basically the range and the spectrum of the places that patients could go to. And those are the needs that we sort of use on an objective basis. Again, nobody is going to be the same as the other person, and those things that we do are going to be important that we measure them and keep an eye on them and watch for progress in terms of their needs as time goes on and as their condition changes over time. Okay. 2 minutes. Okay. Yeah. Okay. Well, I just want to tell you one thing, and then we're going to just go through the chart one last time, and then we'll take the questions. So again, with the guilt part of caregiving, I think is something that's important to reiterate. And I think you really have to leave here patting yourselves on the back, patting each other on the back, because being a caregiver is really, it's a mission. And as I said, it's a zechus to have that mission, and we should take it at that, look at that. But caregivers do feel guilty sometimes, and they can be dedicated, but sometimes they feel like they're martyrs. And it's not our job as caregivers to feel like we're martyrs, because then you're not a good caregiver. You have to do it feeling like you're doing what you want to do. If you have the right facility, if you have the right help, if you have the right vision where someone should be and when they should be there, then you could take off the hat of martyrdom and you could put on the hat of being a caregiver again. And that will give you the opportunity to spend your time giving care in an emotional way that will be helpful to you and to your loved one. And then we could sort of accept this aspect of being human without that discomfort. And that way is one of the ways we could be the best caregivers that's possible. So if we just look at the chart quickly, so the boxes should be easy to fill in now. Living at home works when the person's needs are not so significant. Independent living will make it easier for them to get to that level with a little bit of aid, but they can still be independent. When they exceed that responsibility, and then they could go into assisted living and the skilled nursing facilities when they exceed those needs. I just want to point out that I mentioned that like a patient on a ventilator. There are patients who are on ventilators and feeding tubes and catheters that can be cared for at home, given the right setting, the right physical environment, the right geographic environment, the right medical staffing. Those things are possible to be done, but not for everybody. If you can do it, call a kavod, and if you can't, so then you just have to make sure that the needs are filled in a proper way, in a safe way.
You want to say more? I'll tell you what, while Dr. Carey is summing up, why don't we pass the questions up to me?
You can take part by hands. It's not.
Okay, do you have any questions? Any other questions? Okay, one question. Can OTPT at home be covered by Medicare as opposed to community Medicaid home care?
Okay, so I'm going to not answer into financial questions. There are probably people who are much better suited upstairs to answer some of those questions. And it will depend on the coverage. Most of these questions will depend on the coverage. Some people's coverage is very comprehensive, some is not as comprehensive.
Any other questions? You want to just read it? Should I read it? Okay. I'll read it. Okay. Could you speak to potential for neglect and abuse in both settings?
There is potential.
Yes.
That's an easier question. There is. Obviously, with any aspect of the care someone has, part of the job of the caregiver is to do their homework and try to do the best. I had a patient who had the family hired privately, a wonderful woman from Russia. She was a physician there, and she lives in the home, in the apartment with the person she cares for 24 hours 7. And she said, I can't manage 24 hours a day. I need some help, at least so I can sleep at night, because the patient was not sleeping. So they hired someone to come at night. So they called me a few days later, and the aide, her name was Nina, said, we had this person, but since she's here, not only doesn't our patient wake up at night, but I can't even wake her up in the morning. And what happened was, every night this person would come in and just slip her something to make her sleep, and it didn't take too long to realize that was not exactly what we wanted the person to be there for. So yeah, there's this abuse. Even people who are potentially well-meaning, she may have thought she's just giving a sleeping pill to help her sleep through the night. Obviously they can't mix medicines, but there's always a potential for abuse. Another story of someone who had a mother in a nursing home. I'm not advising. I'm just telling something I heard. And he put in one of those baby cams, babysitter cams, into his mother's nursing home room in the nursing home to track what was going on. So the answer is you need to be vigilant. You need to do what we do with other aspects of our house. A lot of people have housekeepers, so they make sure to stop into their house all the time unexpectedly so that the kashrus of their house is not an issue. You need to make visits as much as you can. So the answer is, that is a potential, and it's our responsibility as much as we can take it to try to avoid it.
Does having somebody from an agency help you because they're supposedly screened and bonded?
So the answer is supposedly it does help. Obviously, again,
lawyer also?
if you really try to get whatever references you can for people, and that's the best you can do.
Any other questions?
But it is an important point.
What if the person is reluctant to go to assisted living and wants to stay home? I mean, at what point are they Forced to.
So that's an excellent question, and probably the second most burning question. The answer is there's no answer. But it's probably more of a process. And like I started out saying, that planning for everything is a good idea. Once this even surfaces a little bit as a possibility, probably the best method to do is, if a person again is capable of having the conversation, and very often they are, is to sort of discuss it with them. Bring it up every so often, discuss the benefits of going somewhere else, discuss the reasons why staying home is not so great, because you don't have the same number of people coming to visit. You don't have the same independence as you think you have. Break it to them slowly, break them into them the benefits and the side effects or the detriments of not being somewhere else. Maybe take them there for a visit. Some of the facilities will actually let someone stay there for a month or a number of days as a trial period to see if they like it. All those opportunities are the ways you could do it. So if someone you can have the discussion, in some ways you're a step ahead, and in some ways you're a step behind. If you need to convince somebody completely, then you need to go through this process. For those who don't have the competency to make the decision, sometimes it's an easier process, but it's not something you could discuss. So really, if you make it into a process, you get other individuals to come speak to them who have been through it. You have other people in family, other members of the community that may know them and may be able to discuss with them. And paint as rosy a picture as you can, which is realistic, to try to do that. Again,
I want to just tell a quick story about this. I took care of my mother-in-law at home. I was running to Manhattan. She was fully competent at the age of 90, but I was running to Manhattan every day to do her shopping, her cleaning, and everything. And finally I said, I can't. And we literally, she, thank God, broke her hip, and I just didn't take her home from the hospital to her house. I took her to mine. I moved her, did construction and everything, kicking and screaming. About a month after that, she's talking to her sister on the phone, and she says, I'm so glad I had the idea to come live with my children. So sometimes I think when you demonstrate
Interesting, it was an incident that...
Right. Well, she didn't have a choice. She thought she was going home. I told her I forgot to pay the rent and she was evicted. There was another question?
often the coincidence is the precipitating factor.
Right. There were two more questions, and then Mincha is afterwards upstairs. I just was asked to remind people, and also the vendor expo is still going on. So one and then two.
Would you recommend or not recommend a person with Alzheimer's and dementia to be in a assisted living type of thing? Or just like, I don't know if it's called, we don't mention names.
I'm not here to promote them, just that's my experience. And they were in the last session, so they were happy. The answer is, it's a very good question. You know, what level? And the answer really is, it depends a lot about the level of the dementia. It depends the level of the assisted living. Like I said, they're not all the same. Some assisted livings, you know, I've been to some others, and if the residents are not capable of getting dressed and coming down to the dining room as if they're going to a restaurant, and they can't walk without a walker, and they do not need an aid at all, then they're not candidates for that institution. The Nordals, and I'm not here to promote, I'm just saying that the Nordals happens to be much more, I don't know if the word is liberal or what the word you want to use, but they have individuals there who are complete dementia, who need 24 hours services. What they don't have are patients, or can't, I call them patients because my perspective, but they all can go to the dining room and eat. Many of them need to be fed, and they're capable of doing that. That's almost the barometer. So the answer is, it could be done. It depends on where. It depends on how much the institution is willing to work with you, and it depends on the level of care you can provide for them. It's not perfect, and some of them could pass for people who are eligible for a nursing home. So the answer to the question is it possible? It's possible. If it's recommended, it would really depend on all those other circumstances. But if you want to know, the best thing to do is go to one of these facilities and look around and see who's there and see what level of function they are.
This lady had a question.
Yeah, in the order of Kibbud Av V'Em, you have a parent, mine is 96 years old and has beginning onset late-over dementia. And she's refusing even to have an aide come into the house because she's protective of her own environment, never wanted strangers in there, for sure. How do you begin to approach that? I heard you talk about the process, but she just does not want anybody there.
That's obviously probably more common than the success of going through the process. Honestly. The process is still the process. And as I also said, sometimes we take that bold step to accept the responsibility of safety issues versus giving them what they want. And quality of life is not something to snicker at. That's a big deal. But and then you really should be involved with it.
Well, I'm the sole caregiver, 7 years.
So that's right. So if it's, I would say, so you try to share the responsibility with siblings, which is another whole talk, and it's not always possible.
Where do you live? What do you live?
Two Gardens Hill.
Yeah, it's not a simple solution. But if you take a different perspective, if I was on, not me, if someone was on Untitled call and we responded to a patient like that, and they refused treatment, then many EMS services would call the police department, and the police would come in and force the patient to go out. So within that whole framework, we try to avoid those kind of confrontations, but it's not a simple solution so far that sometimes we have to go to those means to handle it. The best you could do is the best you could do, and at May of Esrim, she should pull it off. She said she pulled it off.
I want to thank everybody for joining us. Look forward to